Okay, we are going to be starting the voiceover lecture for medications for depression. There are basically 4 classes of antidepressants that we're going to be covering. The first one is the tricyclic antidepressants, or the TCAs, the monoamine oxidase inhibitors, or the MAOIs, the selective serotonin reuptake inhibitors, SSRIs, and the selective serotonin and norepinephrine inhibitors. There's one more class that we'll touch on at the end, and that's just called the atypical antidepressants, some of those antidepressants that don't fall into any of these classes. I do want to make a note here, though, that medication should not be the only treatment for depression. It should be used in a combination with individual or group or family therapy, some type of counseling. When they've done research on medications or antidepressants, they took 2 different groups: those individuals who were just on medications or antidepressants, and then a group that excuse me, that were on medications but also were receiving some type of individual counseling or therapy or group or family type of therapy. And can you guess who had which group had the best outcomes? The best outcomes were those individuals who had both medications and some type of therapy or counseling. And so this is something that we can really remember and really advocate for with our clients, whether they're inpatient psych or any other place, med-surg patients, anybody that we're taking care of, is to advocate for them. Sure, they might be on antidepressants, but maybe the physician or provider has not ordered or made referrals to a therapist or to a counselor. And we can definitely, if we notice this, ask the provider, can we get a referral? Or, let's see about where they would like to go to counseling, that sort of thing. And and we can definitely educate our clients the importance of seeking counseling to help with issues that are going on in their life and not just using medication. So I just really want to emphasize that point. The action of antidepressants I have written down there. We're going to go into a little bit more detail when we get to each medication, but basically it's making the neurotransmitters norepinephrine and serotonin more available in the CNS. And what you have found out is that when we look at the theories for depression, many of those theories have to do with these neurotransmitters, a lack of these neurotransmitters in the brain or the CNS. First group of medications that we have down here are the TCAs, tricyclics, and I have a list of some of the more common ones. I'm not going to go through all those, but as you look at that, what can you see that is familiar with all of those? They all basically end in INE, so that is a very good way to remember the TCAs. Side effects of TCAs: they definitely have anticholinergic side effects such as dry mouth, blurred vision, constipation, palpitations, urinary retention. So it's important that as we're studying side effects, we also have to know what are the nursing interventions. So to be thinking about what are the nursing interventions for dry mouth? Well, of course, maybe ice chips, maybe sucking on hard candy. Blurred vision should go away within a week or 2, but if it isn't, then we need to talk with a doctor, and maybe there is a better medication for this person. Constipation, we all know the nurse interventions for constipation: high fiber diet, lots of exercise, lots of fluids. They may need to be on a stool softener. Okay, orthostatic hypotension is another side effect of the TCAs, and again, nursing interventions that you are well aware of is to make sure that we take orthostatic blood pressures and monitor that, but also that we encourage them to change their sitting, lying positions slowly before to sit for a little bit before they get up and start walking, so they won't accidentally fall or become very dizzy. Plenty of fluids. Arrhythmias is another side effect, and also weight gain. Let me go back to the arrhythmias. Arrhythmias cause changes in the, or basically these medications can cause changes in the normal electrical conduction in the heart. And so these TCAs can be very cardiotoxic. And we'll talk a little bit about that and the importance of that when patients overdose. One other one that I don't have here that I'd like you to add is a side effect of sedation as well. Overdose should be starred and underlined here. When a person overdoses on TCAs, their overdose is more lethal than with other medications, and this is due to the narrow therapeutic range versus the overdose range. And so patients can accidentally possibly overdose, but when they do overdose, it may very well be life-threatening. Patients with suicidal ideation are given a very small supply or put on another medication. For example, if we had a patient who was struggling with a suicidal ideation and they are on a TCA, we would want to give them a very small supply, say like a week supply, and have them come into the clinic every week to get their prescription, instead of giving them like a 2-month supply or 3-month supply or prescription. So very important to be aware of. And that narrow therapeutic range has a lot to do with that cardiotoxicity, and many patients who do overdose on TCAs end up being in the intensive care unit because of cardiac issues before they're transferred down to the psychiatric unit. Nursing interventions I have down here. First of all, we need to instruct the individuals that antidepressants are very slow to act, usually 2 to 3 weeks. Some people will say up to 4 weeks. So one of the things that we need to instruct them on is that, you may not start to feel better until, day 14 or even up into 21 days, but don't stop the medication. It has to build up, in your system before you're going to start to notice some difference. But for some individuals, as you can imagine, if you're very depressed, waiting 7 days, waiting 14 days, 21 days until you get some relief can be a very long time. And many times patients with depression have a lot of negative thinking and may feel hopeless and just opt to say these medications aren't working and I'm not gonna mess around with them anymore, and may stop the medication. So we need to reiterate and continue to encourage them. Usually the last symptom to improve is a patient's mood, and we can remind them about that as well. You are starting to eat a little bit better, you're sleeping a little bit better. I know that you may not be feeling very well, but we are noticing some improvement. So if you can, just continue this up until, the 21 days, and see if you can't get some relief. And it may be with everybody is very different. So there will be some patients who will not respond to one antidepressant, but they might respond to another antidepressant. So there are those patients who we may have to try on 2 or 3 medications before we find a medication or antidepressant that actually works for them. And again, this is something we can educate them about and encourage our patients with. Precautions. We should not be giving this medication, or they should not be taking this medication with alcohol because of the sedation combination, and they are not to operate machinery or drive, also because of the sedation. If many times after, say, a couple of weeks, that sedation may start to decrease, and then if they are feeling back to normal with no sedation, they can resume operating machinery or driving. We need to closely supervise suicidal patients, especially during early therapy, and I can't stress this enough. The suicide ideations may increase as a patient starts to recover and their energy and their mood increases. Remember what I just said, some of the last thing to improve is usually the patient's mood. They might, like I said, start to eat a little bit better, sleep a little better. Maybe they're getting some of their energy back. And if this person was having suicidal ideation, they just might have that energy to follow through and to follow through on a suicidal thought. So we need to closely monitor when that in early therapy, like in that first week or so or even longer when they start their medication, and we see their energy increasing. We need to teach about all the side effects that we've just talked about here, and then also teach about the treatment of all the side effects, the nursing interventions, if you will, for all the side effects. There is also in your book on page 65 a syndrome that they've just started to discuss, which is discontinuation syndrome. So if you want to turn to your page on page 65, let me get it here. Hold on. Discontinuation syndrome. This is basically where if a person when a patient is coming off a medication, there's always a potential for this syndrome, and therefore antidepressants should not be stopped abruptly, but rather they should be tapered off. Some of the things that can happen in discontinuation syndrome, especially with the TCAs, there's possibility of if they're abruptly stopped, cardiac arrhythmias, GI upset, panic attacks. They could also have hypomania or akathisia, excuse me. And each group of medications has their own symptoms that may occur if they are abruptly stopped. So the main thing to remember is just work with your physician or with your provider and slowly discontinue all of the medications or the meds that you're on. All right, let's move on to the next group of medications, which is the MAOIs. Okay. The MAOIs are used infrequently, usually as a last resort. Usually when they are not responding to other antidepressants, or they might be treatment resistant, and again, like I said, used infrequently. MAOIs, there was a patch. I have not actually seen the patch for MAOIs used within the last 5 years, but there may still be physicians who will order a patch, an MAOI in a patch. Some examples of MAOIs, Nardil, Parnate, are some of the most common ones that we see. Side effects. The person can have hepatic necrosis. They can also have hypertensive crisis, which is very, very important, something that, again, you should star and underline. Hypertensive crisis occurs when foods that are high in tyramine interact with the MAOI and produce hypertension. And so some examples of symptoms of hypertension, they might have, severe headaches, arrhythmias, hyperactivity, stiff neck, like I said, nausea and vomiting, increased blood pressure. And once that blood pressure starts to increase, and we mean severely increase, there's always the potential for that person to have internal bleeding, and then a stroke can occur. So this is a very, very serious side effect that we take seriously, and therefore we often use this medication as a last resort or used infrequently. The person could also develop a hypertensive crisis if they take some of the over-the-counter medications like cold medications, decongestion, so we also have to be careful with those as well. All right, one of the big interventions here for people with MAOIs, they need to be on a low tyramine diet. And I want to talk a little bit about this. Tyramine, which is amino acid, is released from foods that undergo fermentation and or hydrolysis, but we call it fermentation. And this inhibits the MAO, and it allows tyramine to reach adrenergic nerve endings, and this releases excess norepinephrine, which can cause a hypertensive crisis. Now, I'm not going to quiz you on all the details, but this is why it is important that a person is on a low tyramine diet when they are taking MAOIs, that tyramine can interact with the MAOI and cause severe hypertensive crisis. So what is commonly on low tyramine diet, I have or things that people need to avoid. These things that I have listed here on this slide are things that need to be avoided and not having. Red wine, cheddar, aged cheeses, so any aged cheeses, chicken liver, pickled, salted, preserved types of foods, So anything with that's fermented, anything, sauerkraut, anything, that would be pickled fish, any of that sort of thing. Beer should be avoided. Chocolate should be avoided. Coffee should be avoided. Aged meat, smoked meat like salami, deer sausage, anything that's smoked, all of those things should be avoided. I also have starred down here spinach, raisins, and prunes are things that have recently been added to this low tyramine diet. So just to remember that. Now, if you look at the stuff that's on the slide, it might, if you just kind of think to yourself, some of these things would be very hard to avoid: chocolate, coffee, beer, and that is why this medication is prescribed, as a last resort, because this low tyramine diet may be difficult for many people. You could also add dates on this after the prunes, and bananas can be on there as well. So you can add those. The next medication are the SSRIs, selective serotonin reuptake inhibitors, and this group of medications only works on serotonin. So you can look at some of the medications that are on this list, and you have probably seen many of these or heard of many of these. Prozac was the very first one in this group, very common. Paxil, you may have heard of. Lexapro also is very common. Zoloft. Side effects for the SSRIs. All of the side effects that I just talked about with the TCAs may be possible here, but if the person does have those side effects, they generally are going to be less severe. All right? But they can have their own side effects, and or in additional side effects besides the TCA side effects. And one thing that kind of helps me remember some of the side effects from the SSRIs is that there is some activation, which is common with a lot of these side effects, or a more energized type of state. And I'll mention those as we go along. Sexual dysfunction is one on here, and this is one of the side effects that usually causes people to want to discontinue it, or just to discontinue it on its own. So that's something that we should be assessing and definitely educating them about, and letting them know that if they have sexual dysfunction with one SSRI or with one antidepressant, there probably are some others that we can look at that may not have that side effect. So let's stay in communication about that. We don't want you to go untreated or stop medication without letting us know. Hyperactivity, kind of that more energized activation state. Nausea, which you could say is more kind of energizing of the GI system. Mild sedation does not really fit with that energizing, but we can have hyperactivity, or you can have the opposite, mild sedation. Insomnia, again, kind of that energized state where they can't fall asleep. Anorexia, meaning just a decreased appetite, no appetite. Anxiety and tremor are other side effects. Another side effect, if you will, that can happen on an SSRI is serotonin syndrome, and this is when two or more medications that increase the levels of serotonin are taken at the same time. And what can happen with a serotonin syndrome is that the person can have mental status changes. They can have autonomic changes like increased blood pressure or decreased blood pressure. They can have neuromuscular changes like muscle rigidity, restlessness, tremors, and seizures. You can also add on there diaphoresis and an increased temperature. Now, what we do for serotonin syndrome is we stop the medication and treat with supportive measures. Okay, so we treat the restlessness, muscle rigidity, tremors, seizure precautions, treat the temperature. But again, the seriousness in this is that a person could possibly have a seizure, and we don't want that to happen. Okay, nursing interventions. Basically, the nursing interventions we've already talked about, they're the same as the TCAs with the addition of, educating about, the side effects, the different side effects, and also to making sure that we're always assessing for serotonin syndrome. With the antipsychotics, we learned a lot about some of the life-threatening side effects that those individuals can have. Same here with the serotonin syndrome. So when we do our assessments on our patients, we can't, vital signs are very important. Those can give us a lot of clues to what's going on with our person. Neuromuscular changes, mental status changes. So whenever we're making rounds on our patients, we don't want to take any of our assessments too lightly or not do, those full assessments. All right. The SNRI, or the selective norepinephrine reuptake inhibitors. Effexor, that's spelled wrong, that should say E. Effexor and Cymbalta are two examples. SNRIs, they inhibit the reuptake of serotonin and norepinephrine, mainly just focusing on the norepinephrine, but there's a little bit of serotonin in that as well. Side effects are very similar to the SSRIs, and also you can have a increased blood pressure with this SNRIs. Now, one thing that I want to talk about and puts a lot of emphasis on is that when a patient stops one antidepressant, maybe because it's not working, and starts up another antidepressant, we always have to make sure they have a washout period. And a washout period is basically we wait for this washout period. It might be a week or roughly a week before we start another medication. All right, because we don't want them to have too much of a buildup of serotonin, and so we really want to avoid that serotonin syndrome. So we just have to be careful about that. The last group of medications is the atypical antidepressants, such as Wellbutrin, Trazodone, Cerazone, and really the only thing I want to say about this is that let's start with Wellbutrin. Wellbutrin, also called bupropion, that inhibits the reuptake of dopamine, norepinephrine, and serotonin. So that's kind of unique with Wellbutrin, is that it actually is working on 3 different neurotransmitters. Wellbutrin also has a decreased incidence of weight gain, and the sexual side effects are low with Wellbutrin. Trazodone, you might have heard Trazodone before. This is a medication that sometimes is also given as a sleep aid, but if you notice your patient's dosages, usually a Trazodone for a sleep aid is ordered like 50 milligrams or 100 milligrams. It's never given in the full dose as it would be given for an antidepressant. Usually Trazodone, when it is being given for an antidepressant, which actually you don't see very often, is usually 150 milligrams to 200 milligrams. So again, making sure that you're checking your drug references to your medication before you give it, and to understand, why is my patient getting this medication? Is he getting it for an antidepressant, or is he actually getting it as a sleep aid at bedtime? I have another slide on here, ECT, that has nothing to do with medications. ECT is electroconvulsive therapy. I'm not going to be asking you any questions on the exam about ECTs, but just be aware that you should make sure that you study ECTs for HESI, because I'm sure that they will have at least, and you never know with a HESI how many questions, but just to look at that and be familiar with it, okay? And the last thing I have is vagal nerve stimulator. I'm not going to be going over that at all, and they will not have any questions on HESI about the vagal nerve stimulator, but maybe we can talk about that in a clinical post conference, or you can ask your clinical instructor about that very interesting treatment as well.